Hello, everyone. Welcome back to another day of our NCLEX review session. So for those who are new to the channel, you are welcome to join with us for our interactive NCLEX review session. We are currently on day 71 out of the 90 days. And you're also invited to enroll to our comprehensive NCLEX review course at www.stancoastnclexcoaching.com, where you'll be able to access 3,000 NCLEX questions on top of the 200 NG test questions. And we have also updated our library of on-demand videos and also the animated video series. So kindly check on that link below in the description box so you'll know more about us. And this is included with, of course, your subscription for the entire 6 months. And please don't forget to like this video and also subscribe to the channel if you haven't done that yet. And also share this video to your friends who are also reviewing for the NCLEX examination. Now, we're going to have to tackle today's drill, and we'll focus more on the Addison's and the Cushing's syndrome. So hang tight. We have prepared questions for you today. So let's get started with our first question. It states here, a patient has been admitted with an Addisonian crisis. Which statement made by the patient indicates that further education is needed? A, I usually eat out a lot and my meals tend to have plenty of added salt. B, I couldn't take my hydrocortisone because I was sick with the flu earlier this week. Or C, I always double my hydrocortisone dose on days when I go for a long run. Or D, I take a larger dose of hydrocortisone in the morning compared to the afternoon. So you need to pick that option that indicates further education. So which is it? Which option is that one? If you had answered letter A, I usually eat out a lot and my meals tend to have plenty of added salt. Well, we know that consuming extra salt is recommended for those patients with Addison's disease because they have that tendency to lose their sodium. They don't have enough aldosterone to cause the reabsorption of sodium in the kidney tubules. So this is an incorrect option. It doesn't require further education. If you answered letter B, I couldn't take my hydrocortisone because I was sick with the flu earlier this week. Will that be the correct answer? We know that when the patient has Addison's disease, if they miss taking that hydrocortisone, especially when they are stressed or if they are sick, this can precipitate the Addisonian crisis. So this patient here will require needed education. They need to continue taking their medication in order to avoid the Addisonian crisis. So this is what we are looking for. If the patient stated letter C, I always double my hydrocortisone dose on days when I go for a long run. This is a statement that reflects understanding what they should do whenever they are going to have to do a lot of exercise, physical stress. This is an appropriate management strategy in preventing Addison's or Addisonian crisis. So we are eliminating this one. If you answered letter D, I take a larger dose of hydrocortisone in the morning compared to the afternoon. Most appropriate here is that the dosing that is actually larger in the morning, this can mimic the body's natural production of the cortisol, which is actually going to peak in the morning. And so the patient will have to a bit smaller dose compared to smaller dose in the afternoon compared to the morning dose. And this is going to also mimic the slowing down of the cortisol level as the day progresses. All right. So our correct answer for item number 1 is letter B. Our patient statement in letter B would require your education. Make sure that they should not miss taking of that hydrocortisone because they don't have the ability to maintain sodium levels. They don't. They have a lack of the aldosterone hormone. That is the main issue in Addison's disease. Let's have number 2. A patient with Addison's disease shows signs of fatigue, poor skin turgor, bronze skin, and vital signs: heart rate 124 beats per minute, respiratory rate 26 breaths per minute, blood pressure 75/42 mmHg, and oxygen saturation of 94%. Lab results got glucose of 64 milligrams per DL, potassium 5.2, sodium of 122 milliequivalents per liter. Which doctor's order should the nurse carry out first? A, give 4 ounces of fruit juice orally. B, recheck the blood glucose level. C, start an infusion of 5% dextrose in 0.9% saline. And D, provide oxygen therapy as needed. So pay attention to the corresponding patient's data. You got there the lab results and their vital signs. So which one would you implement first? If you answered letter A, give 4 ounces of fruit juice orally. Although the fruit juice can help raise the blood sugar, it doesn't really address the much more immediate concern here. Your patient has a blood pressure of 75/42. The patient's glucose is 64. It is also low. Potassium here is slightly elevated. Sodium is in the severe range, severe low. Patient is tachycardic, and they're also tachypnic. Saturation level of 94% is low, not that bad though. So you should prioritize the doctor's order that would address which issue. Are you going to address the glucose level of 64? Would that really be the first priority? Well, our immediate concern here is the circulation. The patient's blood pressure is very low. 100, what is that? That is 75/42 mmHg. You got to be worried here about the perfusion to the body organs, especially the kidneys, the brain, the liver. This is something that you need to deal first. Your patient has hyponatremia as well. So letter A, you can administer the 4 ounces, but it doesn't really address the most pressing issue, which is the hypotension. So we can do this after we have dealt with that hypotension issue, which is to start an infusion of 5% dextrose in 0.9% saline. Why do we have to do letter C? It can correct the hypovolemia and also the hyponatremia. And this is something that you need to do in a case of this patient, especially in an Addisonian crisis. And the 5% dextrose can address the hypoglycemia. That is the sugar in the IV. Whereas the 0.9% saline can address the hyponatremia. So you're actually hitting 2 birds with just 1 stone here. You can address the hypoglycemia and hyponatremia by administering the 5% dextrose with a 0.9% saline. If you answered letter B, recheck the blood glucose level. Again, this is not really figuring out, or this is not going to address the main issue, which is the hypotension. And letter D, your patient's saturation of 94% is low, but not that life-threatening. You got to deal first with the circulation issue of our patient. The perfusion to the body organs is actually compromised this time. So you got to deal with that. Pick letter C. All right. Now, don't forget about the major issues in Addison's disease. You got a problem with the aldosterone, which is not produced in normal quantities. The aldosterone secreted by the adrenal cortex is very low. You also have an issue with the glucocorticoid. Glucocorticoid, which is that hormone that is responsible in the conversion of non-carbohydrate sources into glucose. And that is why when they are in stress or if they are ill, they tend to have low blood sugar because they lack that hormone, the cortisol, that can help in processing the non-carbohydrate sources into glucose. That is why they're going to end up with hypoglycemia. So these are the two main issues in Addison's disease, along with others. But in this scenario, we are focusing on these two. Let's have number 3. A patient presents with symptoms of nausea, vomiting, diarrhea, and abdominal pain. They are thin and weak with a heart rate of 99 beats per minute and blood pressure reading of 86/52 mmHg. Lab results indicate high potassium and low sodium levels. What medication is the doctor most likely to prescribe first? Is it A, cosyntropin, or known as the Cortrosyn, B, dexamethasone, C, fludrocortisone, or what we call as Florinef? We have D, hydrocortisone. Which of these meds will be ordered most likely by the medical provider? So the patient is presenting with these manifestations: nausea, vomiting, diarrhea, abdominal pain. They are thin, weak, heart rate of 99, blood pressure that is low. There is high potassium, low sodium levels. If you'd answered letter D, hydrocortisone, what is this medication? The hydrocortisone is used for treating the patient with a patient that has had the established diagnosis of Addison's disease. So this is going to be prescribed when the Addison's diagnosis has already been established. However, if the medical provider still wants to investigate what this condition is, then they are going to order the cosyntropin, or what we call as the Cortrosyn test. Okay, that is the medication that will be ordered for us nurses to administer in order to detect what condition the patient may have. This is to help diagnose the adrenal insufficiency through the Cortrosyn stimulation testing. And this is a very common test that medical surgical nurses would do. I've done several of this in the unit. And this is something that you will really need to coordinate with the laboratory people, the phlebotomist, make sure that they are going to know the exact timing when this procedure is done. And usually with the Cortrosyn testing, most facilities would require the patient to be NPO for at least 8 hours. And it doesn't mean NPO including water, but NPO on food, okay, but not water. And this is something that will be done, especially in the morning, where the hormone levels are at its lowest. And so what's going to happen here with the testing is that the patient will be tested first with their blood level. There's going to be a collection of their blood specimen before you're going to administer the medication. And then you will be administering that concentropin or the cortisone medication. Okay. And once the medication has been administered, the phlebotomist will have to obtain the blood sample at 30 minutes after the administration, and then again 60 minutes after you gave that drug. Okay, so the procedure is going to start with blood specimen collection first, and then you administer the drug IV. And then what's going to happen here is there will be collection of blood, 30 minutes, and then another blood collection will happen 60 minutes after the administration of the medication. All right, so that is the procedure. If you answered letter B, which is the dexamethasone, this is used in diagnosing a patient with a suspected Cushing's disease. All right, so this is not used for patients suspected for Addison's, but rather Cushing's disease. And we will talk a bit more about the dexamethasone testing later. Another medication we have here is the fludrocortisone or the Florinef. This is a drug that will be used in a treatment or to treat a patient that has already been identified as having adrenal insufficiency, but it is not used for diagnostic purposes. Not used for diagnostic purpose. The same thing with letter D. All right. But here, dexamethasone, this is to help diagnose a patient who is suspected to have Cushing's. So our final answer here is letter A. Let's have number 4. A patient receives IV corticotropin or Acthar, and a serum cortisol level drawn 60 minutes later shows no increase. What should the nurse do first? Is it A, inform the provider to consider a non-functioning adrenal gland, or B, consider a higher dose to address pituitary insufficiency, or letter C, suggest a second corticotropin dose to treat cortisol deficiency, or is it D, plan to repeat the serum cortisol test in 1 to 2 hours? So this is basically the same diagnostic test that we discussed in item number 3. So what would be your first action this time? If you answered letter D, plan to repeat the serum cortisol test in 1 to 2 hours, would there be a need for us to do a repeat? No, this is incorrect. Repeating the diagnostic test is not necessary because the initial result that showed no increase already indicates that there is already adrenal dysfunction. There is no need for us to repeat. The first test or the result 60 minutes after, it's already an evidence that the patient's adrenal gland is not working properly. Okay, so letter D is incorrect. If you answered letter C, suggest a second corticotropin dose to treat cortisol deficiency, would that be appropriate as well? Well, a second dose is unlikely to elicit a different result. And this is also going to delay the treatment as well. So this will not be a good option. So this is pretty much the same with letter D. If you answered letter A, inform the provider to consider a non-functioning adrenal gland. That's the correct answer that we are looking for. Whenever there is a lack of a response in the cortisol level of the patient, there is an issue with their adrenal gland. So immediately we need to inform the medical provider so that they can order maybe another diagnostic test, or maybe they will order the needed treatment for this patient that has the Addison's disease. Okay, so the correct answer here is letter A. If you answered letter B, consider a higher dose to address pituitary insufficiency. Is it really the issue? Is the issue coming from the pituitary? Well, if you are only going to request a higher dose of the Acthar, this is an inappropriate action because the problem is actually happening in the adrenal gland. It is not a problem in the pituitary gland. The issue here is basically the adrenal gland. So this is an incorrect statement right here. It said to address pituitary insufficiency. No. The person here has primary Addison's disease. So basically, the patient has an issue in the adrenal gland itself. It's not caused by the pituitary gland. Now let's have number 5. A 52-year-old male patient with chronic adrenal insufficiency takes hydrocortisone 25 milligrams daily and is scheduled for a cholecystectomy tomorrow. What hydrocortisone order should the nurse anticipate? A, give the usual morning dose of 25 milligrams PO, or B, increase the morning dose to 50 milligrams PO, or is it C, administer 50 milligrams IV before surgery, or D, hold the morning dose and give it after surgery? Your patient has chronic adrenal insufficiency, and they normally take hydrocortisone 25 milligrams daily. But this time they are scheduled for a surgical procedure, which is cholecystectomy, the following day. So as the nurse here, what order should you anticipate the medical provider will order for this patient undergoing this invasive procedure? If you answered letter A, give the usual morning dose of 25 milligrams PO. Take note that they have been taking this drug for quite a while. They have chronic adrenal insufficiency. So the usual dose will be inadequate for them to manage the surgical stress. This is not sufficient for this patient, as they are going to be undergoing an invasive procedure. This will add more stress to their system. They will require an increase in the dose of their steroid. So the 25 milligrams PO is insufficient. The defining factor here is the cholecystectomy. That is more than enough stress that they can handle. Okay? You need to obtain, or you need to anticipate the medical provider to order some more, which is letter C, administer 50 milligrams IV before surgery. And when you're going to encounter an test question like this one, Addison's disease, any patient that may be undergoing any kind of stress, or if they are ill, and if they have been already taking that normal or routine dose of the steroid drug, when they are sick, when they're going to be getting a dental procedure, surgery, their dose will be increased. Okay, and this is to prevent Addisonian crisis. For letter C, administering that 50 milligrams before surgery, this is to manage the added stress for this patient. Okay, so that's the no other rationale but that one. So we are going to mark this letter A incorrect. Letter B, increase the morning dose to 50 milligrams PO. There is an increase in the dose, but with the route, which is PO, this is not going to really cover the patient, especially that they will need a medication that will have a much rapid or faster response. Okay, so in a case of a surgical procedure, they need to have a additional medication that is in a form of an IV. So this will provide a faster response. It will cover the patient for that entire procedure. If you answered letter D, hold the morning dose and give it after surgery, yes, this can lead to Addisonian crisis. They should get the routine dose plus the additional IV. Okay, our correct answer here is letter C. Let's have number 6. A nurse is teaching a patient with Addison's disease about managing their condition at home. What information should be included in the teaching plan? Select all that apply. A, Addison's disease is temporary and resolves in a few weeks. B, avoiding stress and maintaining a balanced lifestyle helps prevent flare-ups. Or C, symptoms like fatigue and mood changes should be reported to the doctor. Or D, a medical identification bracelet should be worn at all times. Or E, family members need to learn the warning signs of adrenal crisis. Or F, medication doses may need adjustment for dental work or surgery. So what information should you include in the teaching plan for this patient so that they can manage the Addison's disease in the home setting? You have to select all that apply. So take several or take more than one pick here. Mary answered B, D, E, F. Okay. If you answered letter A, Addison's disease is temporary and resolves in a few weeks, this is an incorrect statement. It doesn't resolve. It's not temporary. It is a chronic condition. Those are incorrect words. The Addison's disease is chronic. It's not temporary. And it requires lifelong treatment. It doesn't resolve in a few weeks only. Lifelong treatment is needed for these people. Okay? If you had answered letter B, avoiding stress and maintaining a balanced lifestyle helps prevent flare-ups, this is a correct statement because we know that stress can trigger adrenal crisis. So they need to be taught in managing their stress, avoid stress at all costs. All right. Let's have letter C. Symptoms like fatigue and mood changes should be reported to the doctor. Yeah. Fatigue and mood changes basically are signs that they don't have enough cortisol. They are probably in the middle of an impending adrenal crisis. Okay? These are manifestations of impending adrenal crisis. Fatigue, mood changes. Yeah, they should report these manifestations to the medical provider ASAP. If you answered letter D, a medical identification bracelet should be worn at all times. This is what we call as the medic alert bracelet. This is something that you should also include in the teaching. This will provide the patient some kind of a protection just in case they will be out in the public and they probably would be found unconscious because of the Addisonian crisis. So for those people that are not familiar with this patient, they can just look into that bracelet, and hopefully they will relay that information to the responder when this patient would be transported to the hospital. So they need to have that one. If you answered letter E, family members need to learn the warning signs of adrenal crisis. Of course, they need to have that education as well, so they will be able to help out. Also prompting needed action in case of an emergency. If you answered letter F, medication doses may need adjustment for dental work or surgery. Yes, we already talked about this. There's going to be a need for them to increase their dose, especially when there is a possible surgical procedure, or if they are under stress, maybe taking an examination. Yeah, that's actually one of the conditions there. So this is also part of the treatment. So our answers for this question are the following: B, C, D, E, and also F. F is also correct. B, C, D, E, F. So we only have one incorrect option, which is letter A. The rest are all necessary aspects of your education. Okay? Let's have number 7. What key topics should be included in the teaching plan for a client newly diagnosed with Addison's disease who will begin taking corticosteroids? A, watch for signs of high blood sugar. B, adjust steroid doses based on diet and exercise. C, notify the doctor if your blood pressure spikes suddenly. Or D, reduce the steroid dose during stressful situation. The question is stating what key topics should be included in the teaching plan for a client newly diagnosed with Addison's disease who will begin taking the corticosteroid. Okay, take note, guys. We are talking about the corticosteroids, the cortisol hormone. Remember that it is a hormone that can cause spiking of the patient's blood sugar, right? It can promote the conversion of non-carbohydrate sources to be converted into the glucose. We are talking about a corticosteroid. So if you answered letter D, reduce the steroid dose during stressful situations, this is an incorrect teaching because the patient should have an increased dose during stress. Reduce is incorrect. The dose should be increased during stress. They need that to prevent Addisonian crisis. If you answered letter C, notify the doctor if your blood pressure spikes suddenly. Take note that the medication can actually lead to the hyperglycemia, even though it can cause retention of the water or fluids. It can also retain the sodium, but this is not as much critical. This is not as critical compared to having letter A. All right. Although the medication can also cause a high blood pressure, but talking about spikes, it doesn't really do that. The patient who will be taking the corticosteroids will not have spikes, but rather a gradual increase. All right. And Letter A, which is basically watch for signs of high blood sugar. This is what we need to teach our patient. As we know that the medication can lead to hyperglycemia. So again, we are going to teach them to identify those manifestations of hyperglycemia. Okay? This is what we are looking for. If you answered letter B, adjust steroid doses based on diet and exercise. There is no such thing as according to exercise or diet. The patient should be taking a consistent dose for this medication. They should not be independently doing this on their own. They should follow what has been prescribed to them. Okay? This is incorrect. There should be consistent dosing schedule. And the dose should be, what do you call this? It should not be changed according to what they're eating or whatever the amount of exercise they're doing or level of activity. It's not based on that or in those kind of conditions. The patient has to consistently take that medication in order to establish therapeutic level of that glucocorticoid. Okay? It's not like an insulin that is based on a sliding scale. Nope. So our correct answer here, it is letter A. Teach them about those manifestations of hyperglycemia. Again, guys, we are inviting you to enroll in our NCLEX course. So kindly check on our website, or if you want to check on that description box below, kindly click on that link. All right. And please don't forget to hit the like button as you are watching this video. If you have already spent at least 20 minutes watching this video, probably you're still interested by now, so kindly hit that button. All right? Let's have number 8. A patient with Addison's disease is taking glucocorticoids at home. Which statement shows they understand their medication? Is it A, I'll need to change my glucocorticoid dose depending on different situations? B, I can stabilize my dose and take the same amount once daily? C, glucocorticoids build up, so I'll take a dose every 3rd day. D, I'll take a dose every 6 hours to maintain steady glucocorticoid levels. So you're going to select that statement made by that patient that shows evidence that they understand the glucocorticoid therapy. If you answered letter D, I'll take a dose every 6 hours to maintain steady glucocorticoid levels. Every 6 hours, that is unnecessary. And it doesn't really reflect understanding regarding the dose for this medication. There's no such thing as every 6 hours. We are going to actually try to mimic the effect of the internal function of that steroid, as if quite similar to a normal person, right? So the patient will require that dose during the morning in order for them to carry out the normal daily activities. And of course, the medication will kind of tend to diminish its effect towards the end of the day, right? Of course, that's the time when the patient is supposed to rest. And so having that every 6 hours to maintain that steady glucocorticoid levels is not really necessary. This can have some detrimental effects into the body systems as well. Letter C, glucocorticoids build up, so I'll take a dose every 3rd day. There's no such thing as building of the levels of the glucocorticoids and not taking it consistently. They are not going to accumulate in the body. So the patient would be required to take this medication every day, consistently. Every 3rd day, that is incorrect. There should be daily schedule. Okay. If you answered letter B, I can stabilize my dose and take the same amount once daily. That is the correct. Is that really the correct answer? I can stabilize the same amount. You think that would be the same amount. I can stabilize my dose. This is partially correct. And take the same amount once daily. What is usually a standard dose in a patient in taking the glucocorticoid is that they're going to have a varying dose in the 24-hour period. Most of them will be taking a larger dose during the daytime, and in the afternoon they will have a smaller dose. Again, this will mimic the natural secretion of the cortisol. So, not the same amount once daily. It is going to be taken in a split dose. One in the morning and one later in the day. A smaller dose in the towards the later part of the day. If you answered letter A, I'll need dose depending on different situations. This is basically reflecting understanding that if there is an expected stressful situation, like a possible procedure, like dental procedure, surgery, if they are facing such kind of like a stressful situation, maybe a new job, if they are too excited about it, yeah, that can cause that Addisonian crisis. Another would be an illness. If they are feeling somewhat kind of like in the middle or towards, or maybe they're in the middle of an infection, or maybe they're progressing toward a phase of an infection. This is something that would call for an adjustment in their dose. So this is letter A. Our correct answer is letter A, not letter B. Okay. Let's have number 9. A patient on a morning regimen of 25 milligrams hydrocortisone for several months mentions experiencing fatigue in the late afternoon. What should the nurse suggest the patient bring up with their healthcare provider? A, incorporating a mineralocorticoid into the treatment regimen, or B, evaluating serum electrolytes for potential drug toxicity, C, raising the daily dose to 50 milligrams, and D, splitting the daily dose into morning and afternoon doses. So your patient has been taking this medication for quite some time, several months, but they are now experiencing such kind of fatigue, especially late in the afternoon. What would be the correct answer here? Would that be letter D, splitting the daily dose into the morning and afternoon doses? Yes, like I've said earlier, as the time goes by, when the patient has already taken this medication for quite some time, they will eventually feel that kind of fatigue as their body will get used to the routine daily schedule. So the best suggestion here would be to do letter D, splitting the daily dose into morning and afternoon doses. This can help the patient sustain their energy throughout the day. And again, this will help mimic the body's natural cortisol secretion pattern. So a bigger dose during the day, a smaller dose during the later part of the day. Okay? Splitting. If you answered letter B, evaluating serum electrolytes for potential drug toxicity, take note, guys, that the patient is complaining about fatigue. Fatigue is a sign that they are under stress. They are not able to cope with the demands, the stressor the physical activity as the day goes forward, they will get so tired. So that simply means that they're not able to maintain that cortisol level. Even if they still need to do a whole lot of activities during the late afternoon, yeah, that's a sign that they are not able to maintain the cortisol level. So definitely we need to suggest letter D here. It's not a sign of drug toxicity. Letter B is incorrect. Not a sign of toxicity. The patient that has toxicity will actually have high blood pressure. They will have fluid retention. So, toxic signs, steroid. Toxic signs are the following: elevated blood pressure and fluid retention, not fatigue. Fatigue is a classic manifestation of Addison's disease. So we need to treat that fatigue by having them talk with their medical provider about splitting their dose. If you answered letter C, raising the daily dose to 50 milligrams, letter C, this is incorrect, because if we are only raising the daily dose to a higher amount, this can lead to unnecessary side effects. The cause of the fatigue is basically that they are not being able to maintain their cortisol level because they are getting it as a daily dose only. What they need to have is a split dose, okay? Not a daily dose. Okay? If you answered letter A, incorporating a mineralocorticoid into the treatment regimen, what is that mineralocorticoid? What we need to, the mineralocorticoid is incorrect. It's because the mineralocorticoid is to treat the sodium and the potassium balance. And this is not going to be helpful in addressing the fatigue, okay? So this is only to treat sodium, potassium imbalance. Remember that when we were talking about a mineralocorticoid, this is basically aldosterone, right? Our patient that has the adrenal hyposecretion, they lack the aldosterone. And so if the option stated incorporating a mineralocorticoid into the treatment regimen, our patient really is this is not gonna be therapeutic for this patient, since they're only experiencing the fatigue, which is basically a result to the reduced cortisol level, not reduced aldosterone, okay? We're gonna need this aldosterone if the patient will become hypotensive, all right? And if their potassium level is way too high. But at this point, we don't have that information, and so we are not gonna select that option. Our correct answer here is letter D. Let's have number 10. A patient with Addison's disease has been prescribed cortisone acetate and fludrocortisone acetate as replacement therapy. What is the best dosing schedule for these medications? Is it A, administer both medications 3 times daily, or B, take the full dose of both meds in the morning, or C, take all of the fludrocortisone and 2/3 of the cortisone acetate in the morning, and the remaining cortisone acetate in the afternoon, or D, divide each medication into 2 doses, 1/2 in the morning and the other half at bedtime. What is your answer here for number 10? Your patient is getting cortisone acetate and also fludrocortisone acetate as replacement therapy. If you answered letter A, administer both meds 3 times daily. If you're going to have to give this drug this much of a frequency, this can lead to excessive dose. This will disrupt the patient's diurnal pattern or cortisol secretion. Excessive dose. Another is that it can disrupt the natural diurnal pattern of the cortisol secretion. Disrupts diurnal pattern. Okay? Like I've said earlier, when you are administering the steroid, it has to at least mimic the natural secretion of the cortisol. It should be a lot higher during the morning and somewhat kind of lower, or somewhat kind of like a lesser dose in the afternoon. Because if you're going to give that 3 times a day, it will really cause a spike of the cortisol later in the evening. They will not be able to rest. They will still be hyperactive later in the evening if they will be taking that dose with the same amount towards the later part of the day. So we are going to eliminate letter A. What about letter B? Take the full dose of both medications in the morning. Again, this is daily dosing. This will not be able to sustain the hormone levels throughout the entire day. And again, this will lead to the fatigue in the afternoon. So letter B is also incorrect. In the morning is not recommended. Right? The patient should have at least some amount that will help them to sustain throughout the later part of the day, which is basically to allow or administer the medication to have the fludrocortisone and 2/3 of the cortisone in the morning, while they will be taking the remainder of the cortisone acetate in the afternoon. This will prevent the fatigue. Okay? Like I've said, we should mimic the natural hormone rhythms of the cortisol. Right? This will prevent fatigue. If you had answered letter D, divide each medication into 2 doses, 1/2 in the morning and the other half at bedtime. Again, this is not the option that we are looking for. We need to follow the natural cortisol production. Okay, we need to mimic that pattern. So this is not doing that one. So our correct answer, it is letter C. Let's have number 11. When educating a patient about taking oral glucocorticoids, what instruction should the nurse give? Is it A, consume your medication with a full glass of water? Or B, take your medication when your stomach is empty? Or C, take your medication before going to bed to enhance absorption? Or D, take your medication with food alongside an antacid? Oral glucocorticoids. What would be the appropriate teaching that you should provide to your patient? Would that be A, B, C, or D? If you answered letter A, consume your medication with a full glass of water, this is not going to address the potential adverse effects of the drug. We know that oral glucocorticoids can cause GI irritation, gastrointestinal irritation. Just merely taking a full glass of water will not prevent that. No. What you're going to teach them instead is to have them take the oral glucocorticoid with food. This will prevent the development of the GI irritation. We know that glucocorticoids are ulcerants. They can cause gastric ulcers. All right? Prevents gastric ulcer. Should be taken with food or a possible antacid. Okay? Letter B, take your medication when your stomach is empty. No, that's the exact opposite. You're not helping your patient. You are promoting GI irritation and ulcer. If you answered letter C, take your medication before going to bed to enhance absorption. As we had said earlier about the treatment, the medication is not to be taken during the later part of the day, which is evening. This can disrupt the normal pattern of the cortisol secretion. It can disrupt the sleep patterns of the patient, right? What the patient should be doing is to take it earlier during the day. And as recommended, it should be a split dose, one in the morning, and a bigger dose in the morning and a smaller dose in the afternoon. Okay? But this is just a general instruction, guys. But basically, they should not be taking that medication in bedtime or at bedtime. It does not enhance absorption. Alrighty, our correct answer here is letter D. Should be taken with food. It can interfere with absorption. That is quite true, boss babe. But for those patients that already have an issue, they probably have a pre-existing ulcer. And so we don't want to cause more complication into this patient that will need to take their glucocorticoid. They still need to get that. And so if you are not really being proactive, you're not going to give that protectant, which is the antacid, then it's not really going to help the patient. It will worsen their pre-existing condition, or if they already complained of the GI irritation, yeah, we need to prevent that. Okay. And as we know that this is going to be a chronic, this will be a lifetime treatment. It's not just about a few weeks. It's just not about a few months of therapy. It will be a lifelong treatment. And so prevention of ulcers would be so important for this patient. And so eventually, even if they're going to be taking food, which is highly recommended, which is ideal, but eventually they're going to require the antacid because of the nature of the medication. Okay. Number 12. Which lab findings suggest that the treatment for a patient with acute adrenal insufficiency is effective? Is it A, rising serum sodium levels, B, lowering blood glucose levels, C, reducing serum chloride levels, or D, increasing serum potassium levels? Our patient has adrenal insufficiency, but you are asked right now, what finding or lab findings suggest, or what evidence here is simply signifying that the treatment is working, it is effective? Would that be A, rising serum sodium levels, B, lowering blood glucose levels, or is it C, reducing serum chloride levels, or letter C, increasing serum potassium levels? Take note that when you have Addison's disease, your sodium level is low while the potassium is high, right? Which lab findings suggest that a treatment for a patient with acute adrenal insufficiency is effective? We don't have any other answer but letter A, of course. Our patient is lacking the aldosterone, right? They do not produce adequate amounts of the aldosterone, and that is why their sodium levels are low. So we are going to treat this patient with acute adrenal insufficiency to make sure that their sodium levels will be normalized, right? This is basically what the goal of therapy is. We want to increase their sodium levels. Yeah. We don't want to increase their potassium levels because in adrenal insufficiency, their potassium levels is already increased. Remember about the main regulator of the potassium? Aldosterone. This is actually the very important regulator of the sodium and the potassium, mainly secreted by the adrenal cortex. Remember this? We've talked about this in our first lecture, the first day of our live series. The aldosterone is going to cause the reabsorption of sodium ions in the kidney tubules. So, if there is hyponatremia, supposedly, the aldosterone will be released by the adrenal cortex. This will cause reabsorption of the sodium, the salt. And what's going to be the therapeutic effect here? Of course, the sodium level will be restored, normalize sodium level. And of course, the blood pressure will also be improving. If there is hyperkalemia, excess potassium, remember that the main regulator of the potassium is the aldosterone. So if there is a lack of aldosterone, so the potassium would be so happy, hey, I don't have any boss right now, I can do whatever I want. So that's going to happen in a patient with adrenal insufficiency. They will have hyperkalemia because of the lack of aldosterone. And so we need to treat that. If you had answered letter B, lowering blood glucose levels, well, that simply means that the treatment is not effective. The patient should have normalization of the blood glucose levels if you are treating this patient, not lowering. If you answered letter C, reducing serum chloride levels, that is also incorrect. The expected outcome here for the chloride is also, it's not really, it's not directly related, but what we need to look for in this situation is the normalization of the sodium and the glucose, but not really about the chloride. Though it has some affinity to the sodium, but it's not really the electrolyte that we are really going to pay attention to. If you answered letter D, increasing serum potassium levels, well, that simply means that the treatment is ineffective. And this is a classic manifestation of the Addison's disease. So we don't have any other answer but letter A. Let's proceed to number 13. A patient with suspected Cushing syndrome is scheduled for a dexamethasone suppression test. What should the nurse do during this test? Is it A, collect a 24-hour urine sample to measure serum cortisol levels? B, give 1 milligram of dexamethasone orally at night and check serum cortisol levels the following morning? Or C, take blood samples before and after exercise to assess the impact of exercise on cortisol levels? D, inject ACTH 30 minutes before taking blood samples to measure serum cortisol levels. So we are talking about Cushing's syndrome this time. So the patient is undergoing this diagnostic test to establish the diagnosis. So what is the procedure involved in the dexamethasone suppression test? If you answered letter A, collect a 24-hour urine sample to measure serum cortisol levels, this is an incorrect option. Because we know that the 24-hour urine collection is part of the Cushing's diagnosis, but not really associated with the dexamethasone suppression testing. Not associated. If you answered letter B, give 1 milligram of dexamethasone. Take note of the clue here. Dexamethasone suppression test. Are you familiar with this test at all? You got the clue here, guys. Dexamethasone suppression test. So if you answered letter B, this is the correct option. you're going to administer the 1 milligram of dexamethasone PO at night. The following day, in the morning, there will be checking of the cortisol level. There will be blood collection to check for the cortisol level. This is the standard procedure in doing the dexamethasone suppression test. So what is involved in the dexamethasone procedure? What is involved here is that, again, the patient, there's actually two procedures here. There's the low dose dexamethasone. Let's talk about that one. Okay, how am I going to put this screen into black? Screen into white. Okay, let's do that. So there are two different types of dexamethasone suppression test. Dexamethasone suppression test. So the first one is the low dose suppression test. Low dose. So what is involved here? This is going to be done as initial screening to confirm the presence of Cushing syndrome. So this is what we call as initial screening. So the patient is still suspected to have a Cushing syndrome, not yet diagnosed. So what is required here in this procedure is that the patient will be given a dose of 1 milligram of dexamethasone. Dexamethasone, 1 milligram orally in the evening. And then the following day, they will have a blood draw to check for the cortisol level. Next day, okay, in the morning. So again, they will be given dexamethasone 1 milligram orally the night before, and the following day in the morning, let's say 8 a.m. or let's say 7 a.m. They will be there will be a blood sample that will be taken in order to check for the cortisol level. Now, what do you think would be the anticipated outcome if the patient has the Cushing's disease? If they have the Cushing's disease, then what they're going to have is elevated cortisol level. And that means that they have positive Cushing's, not Cushing's disease, but Cushing syndrome rather. Cushing syndrome. If their cortisol is high, by the time you check their blood, they have Cushing syndrome. However, if the cortisol level is normal, or if actually not normal, if the cortisol level is decreased, that simply means that the medication is able to suppress the cortisol production. We know that the dexamethasone is an external hormone, right? If it is given to this patient that is normal, no Cushing's disease, right? If you're going to administer the dexamethasone to a normal person, the outcome of the testing is that their secretion of the cortisol the next day will be decreased. There will be suppression, all right? So there will be a reduced cortisol level in a normal person. However, if they have a Cushing syndrome, the dexamethasone will not be able to suppress the body's cortisol production. They will keep producing even though there is an external source. So our patient here will be diagnosed as having the Cushing syndrome. Now, that is the low dose. There's another one. The second type of dexamethasone suppression test is the high dose suppression test. And what is the purpose for the high dose? This is to differentiate the Cushing syndrome from a Cushing's disease. Okay? So this will differentiate Cushing's syndrome from Cushing's disease. If we are talking about Cushing's syndrome, this is basically an issue with the adrenal cortex. There is excessive production of the cortisol, the glucocorticoid. However, if we are talking about Cushing's disease, this is caused by a pituitary adenoma, which will increase the release of that hormone to stimulate the adrenal cortex to produce more glucocorticoid. So please take note about the two differences. All right. So what is involved in the high dose dexamethasone suppression test? As it's just the name itself, high dose. The patient will be taking 8 milligrams of dexamethasone in the evening, usually around 11 p.m. All right. And then the following day, the next day in the morning, there's going to be blood draw. The same thing with the low dose around 7 or 8 a.m. There's going to be a blood draw to check for the cortisol level. Okay. And so what do you think would be the expected outcome if there is, what do you call this, an adrenal or ectopic tumor? Well, this will cause a little or no suppression of the cortisol levels. If there is adrenal or ectopic tumors, there will be no suppression at all. Okay? No suppression of cortisol if they have a tumor in the adrenal cortex. Okay? Alrighty, so that's pretty much it. Let's go back to our items here. Screen. All right, let's go back to that one. Okay, so if you had answered, so this is the correct answer, give 1 milligram. If you answered letter C, take blood samples before and after exercise to assess. That is not the procedure in doing the dexamethasone suppression test. It doesn't really, it's not involved in this dexamethasone testing. All right. What about letter D? Inject ACTH 30 minutes before taking blood samples. This is incorrect. This is used to detect what? Addison's disease, not Cushing's. Addison's diagnostic test. And of course, yes, 30 minutes, inject ACTH 30 minutes before taking blood samples to measure serum cortisol levels. This is incorrect. This is intended for Addison's disease. Let's have number 14. Number 14, which of the following lab values should the nurse monitor for a client with Cushing's disease? Is it A, low blood sugar after eating, B, low potassium levels, C, low sodium levels, D, low calcium levels in urine? What lab values? Which of the following lab values should you monitor for a client with a Cushing's disease? Will that be A, B, C, or D? If you answered letter A, low blood sugar after eating, that is incorrect, because when they have this condition, they will have high blood sugar, not low. This is incorrect. If you answered letter B, low potassium levels, this is what we are looking for. Low potassium levels. Remember, guys, when we have a patient of Cushing's disease or syndrome, their sodium level is too high. However, they will have very low potassium, which is the exact opposite in the Addison's disease. They will have hypokalemia or even hyperkalemia. And the reason why they will have the hypokalemia because of excessive aldosterone. Remember about the aldosterone as the main regulator of the potassium and also the sodium? It is friendly to the sodium. However, it is kind of like have that frenemy effect to the potassium. They're not best friends with the sodium. I mean, the potassium rather. So they're going to end up with hypokalemia, right? Less than 3.5 milliequivalents per liter. Letter C, low sodium levels. This is a sign of Addison's disease, not Cushing's. Letter D, low calcium levels in urine. Is there such a thing as low calcium levels in the urine in a patient with Cushing's disease? This is actually going to lead to high calcium levels in the urine because of the increased bone resorption. But this is not really a, it's, I would say, less critical than the electrolyte imbalance, such as the hypokalemia. So not low, but rather high calcium levels in the urine. All right. So our correct answer here, it is letter B, low potassium levels. What's the reason? Well, there is excessive aldosterone. Potassium and aldosterone are the best of enemies. They're not best friends. So take that as a reminder when you are going to answer a test question like this. Number 15. A 56-year-old male client with Cushing's disease reports to the nurse that the doctor mentioned the morning serum cortisol level was normal. The client wonders, how is that possible? I'm not just imagining these symptoms. On what concept should the nurse's response be based? Is it A, certain clients may experience symptoms from cortisol even when their levels are within the normal range due to heightened sensitivity? B, a single random blood test cannot reliably measure hormone levels. Or C, Cushing's disease often leads to abnormal cortisol levels due to the disruption of the normal daily secretion cycle. D, tumors secrete hormones, irregularly leading to low blood hormone levels. So simply put here, our patient that has a Cushing's disease, they are complaining that the doctor told them that their cortisol level was normal, but they have a diagnosis of Cushing's disease. How is that possible? Then the reply would be what? What would be your basis in order to appropriately reply to this patient's query? They are somewhat kind of aggravated that they were told that their cortisol level is normal. However, they have a Cushing's disease. Would that be possible? If you answered letter A, certain clients may experience symptoms from cortisol even when their levels are within the normal range due to heightened sensitivity. This is incorrect because the symptoms that a person with a Cushing's disease have are not due to the increased sensitivity. Okay, but rather it is due to the persistent elevated cortisol levels. So this is incorrect. If you answered letter B, a single random blood test cannot reliably measure hormone blood levels. A single random blood test cannot reliably measure hormone levels. We know that single measurements can vary. Yes, it can vary. So instead, specific testing like a 24-hour urine collection will be much more definitive, not this one. Okay, so this will be also incorrect. If you answered letter C, Cushing's disease often leads to abnormal cortisol levels due to the disruption of the normal daily secretion cycle. This is what we're looking for, guys. The reason for this is because the disease itself is characterized by the lack of that normal pattern in the secretion of cortisol. So there will be elevated levels throughout the day, even if a single measurement appears normal. Okay, they will have that elevation, despite that they might be some normal, single normal value. This is a possibility, guys, and I'll explain to you later. If you answered letter D, tumors secrete hormones irregularly, leading to low blood hormone. Tumors secrete hormones irregularly, not low, but actually high blood hormone levels. Now, in support to letter C's answer right here, Cushing's disease often leads to abnormal cortisol levels due to the disruption of the normal secretion cycle. And they are saying, the patient is saying that the doctor told them about the normal cortisol level. There are so many factors why it can be normal, because we know that there is going to be a variable cortisol production. It can fluctuate throughout the day, and this is dependent upon the natural diurnal pattern. And so a single measurement is not going to be reflective of the typical elevation levels in their disease. Okay, so that's one of the reasons. Another is the timing of the test. So if the patient had their cortisol test during the daytime, especially let's say evening or afternoon, this is not going to be as elevated. They will appear as a normal value if this is done later during the day. Okay. Another factor for having that normal cortisol level is probably because of the medications that they're using. They might be some medications that could lead to a normal test result. Or maybe the patient is improperly prepared for the testing. So maybe they are not probably preparing for the testing. They're not following the pre-test instructions. So this can also affect the cortisol level. So again, the single cortisol test that was normal is not really the definitive test for this patient that has the Cushing's disease. It will fluctuate throughout the day, and there are so many factors involved. Let's have number 16. What dietary change, in addition to increased protein intake, would be most beneficial for a patient with Cushing's disease? Is it A, increase overall caloric intake, or B, limit sodium intake, or C, decrease potassium intake, or D, reduce dietary fat to 10%? So your patient has Cushing's disease, but you're asked about what dietary change, in addition to increased protein intake, would be most beneficial for this patient. Would that be A? Would that be letter B, C, or D? If you answered letter A, increase overall caloric intake, we know that they already have hyperglycemia, right? They do have hyperglycemia. They will struggle with weight gain. So they will not really benefit from increasing A high calorie diet, not appropriate. Increase. They already have hyperglycemia. If you answered letter B, limit sodium intake. Take note that they have an increased production of aldosterone. They will have hypernatremia. So instead, what we're going to need to do here is to limit their intake of salt. We're going to have to restrict their sodium to prevent, or to manage rather, their hypertension, to manage fluid retention, which are common issues in the Cushing's disease. So we are going to select letter B, limit sodium intake. If we are going to select letter C, decrease potassium intake, remember that they have hypokalemia. We are not supposed to decrease their potassium intake. Rather, we need to increase it, not decrease. Okay? Should increase K intake. If you answered letter D, reduce dietary fat to 10%. We know that reducing fat intake is part of a balanced diet, but at this level, this is really low, guys. This is not practical, and it's not necessary for this patient with the Cushing's disease. What we should focus here instead would be to manage their sodium and also to limit their caloric intake. All right, we'll have the last question of the day. The nurse is preparing for a client for an adrenalectomy. Which of the following medications might be prescribed before the surgery to prevent Addison's crisis? A, oral prednisone tablets. B, subcutaneous fludrocortisone. C, intramuscular spironolactone. Or D, intravenous methylprednisolone sodium succinate. Your patient is scheduled for adrenalectomy, and this is indicated for those patients that have hyperactive adrenal gland causing the Cushing syndrome. So you are being asked here what medication, which of the following medications that might be prescribed before they're gonna undergo the surgery to prevent the Addison's crisis. Which of the following meds? If you answered letter A, this is incorrect. Oral prednisone tablets. Take note, oral prednisone tablet. This is going to cause a delay in its effect. It is not ideal for rapid therapeutic effect. Delayed effect. So this is not the best option. This would not act quickly to prevent the Addisonian crisis. We are eliminating that one. If you answered letter B, subcutaneous fludrocortisone, this is a mineralocorticoid. Fludrocortisone. This is a mineralocorticoid. This is going to affect the electrolyte balance. The sodium and the potassium, but it will not address the immediate need for the glucocorticoid replacement. Especially, we are talking about a possible adrenal insufficiency. So this is a mineralocorticoid. What we need instead is a glucocorticoid, not mineralo. So we are eliminating this one. If you answered letter C, intramuscular spironolactone, there's no involvement. It's not really part of the treatment. Spironolactone is a potassium-sparing diuretic. It does not provide glucocorticoid replacement. So we are eliminating this one. K-sparing diuretic. It will not replace glucocorticoid. So we don't have any other option but letter D, IV methylprednisolone sodium succinate. This is the drug of choice. This is a glucocorticoid that will have a quick action. This will prevent the Addisonian crisis. Rapid action. And this can prevent Addisonian crisis. Alrighty. So take note, guys. We are actually preventing Addisonian crisis for this patient that will be due for a surgical removal of the adrenal gland. Alrighty. So that's it for today. I hope that you are learning from the drills. Make sure that you like this video, subscribe to the channel, and share this video to your friends who are also preparing for the NCLEX. And we're also encouraging you to enroll into our NCLEX course via our website. So if you want to know more about our offering, click that link below in the description box. So again, everyone, I thank you for your time and participating for today's lecture. And I hope that I'll see you again tomorrow at 9 p.m. Eastern Standard Time. Thank you, everyone, and you all take care. Bye-bye.